suppose that's a kind of fear that I have, is that if you look back to about 2004-ish, when probiotics were the next big thing and everybody was quite excited about them, they didn't really do it. And so now it's almost poisoned the word and people are not as interested in it anymore, you know? And of course, the reason for that is that the organisms that were chosen for convenience purpose and not for specific indication or to fulfill a niche or to achieve a particular microbial effect.
Right.
It was just, we can put this in a yogurt and keep it in the fridge. Let's see what it does to IBD. You know, so no surprise then that they're not very effective. And perhaps for you or I, if we go to a barbecue and we eat an undercooked chicken sandwich and we end up with Campylobacter and we spend 5 days in the toilet and we're not very well, we've gone into dysbiosis, but we then come out of it again. So it's like an unstable dysbiosis where your body can right that and fix that problem.
The following is a conversation with Dr. Richard Hansen, Consultant Paediatric Gastroenterologist, the Royal Hospital for Children in Glasgow, an Honorary Associate Clinical Professor at the University of Glasgow. Dr. Hansen's main research interests are related to that within the gut microbiome. He has pioneered the application of novel dietary methods to children suffering from Crohn's disease as part of a study called CD Treat, and has also been involved in the application of fecal microbiota transplantation, also known as intestinal microbiota transfer, to paediatric populations with inflammatory bowel disease. This is Inside Matters. My name is Dr. James McElroy. I hope you enjoy it. I'm going to go to the Glasgow University microbiome group.
Yeah.
Sort of meeting.
Gummy.
The gummy.
The gummy bears.
Is that what it's called? Yeah, gummy. And that'll be a great opportunity to see
Yeah.
everyone face to face. And also we can present some of the work that we're doing at Enteral.
Yeah.
GRI are the lead site for our clinical study in patients with cirrhosis and HE. So there's a close link there.
Good.
What I'd be keen to explore though is, can we do more in the way of analytical toolkit? Can we do more in the way of studies?
Yeah.
And if so, what's the next indication? I mean, you mentioned UC and we're going to talk a lot about UC and IBD, but there must be a lot more expertise and capability in Glasgow, right? To do work in different areas.
Yeah, I'm confident there is. I mean, it just depends on what area you want to enter. I mean, I'm clearly not, my expertise is narrowed to IBD and probably within that pediatric IBD, but there's interest in microbiome science probably across all of medicine now, do you know?
Right. From
obesity, cardiovascular disease, cancer, altering cancer response to therapy, maybe even. So there's lots of places that you could look to test the product. But
and how's that changed over the last, just say, 5 years in terms of the potential indications in patient populations that microbiome therapy can benefit?
Yeah, I think probably what's happened is we've seen an explosion of interest in the microbiome because it's easier and easier to test for it within laboratory science. And so you've seen lots more groups get interested in that and there are more associations with the microbiome. But probably I still feel, 10, 12, 15, however many years you count it, depending when you start at the beginning of what clinical microbiome science was. I probably still feel that microbiome therapy or microbial therapeutics is just getting started, is in its infancy.
Right, right.
So I think there'll be lots of indications, but I think along the way there'll also be lots of paths that don't lead anywhere, where people will trial something and it doesn't work out. And I suppose that's a kind of fear that I have, is that if you look back to about 2004-ish, when probiotics were the next big thing and everybody was quite excited about them, they didn't really do it. And so now it's almost poisoned the word and people are not as interested in it anymore, And of course, the reason for that is that the organisms that were chosen for convenience purpose and not for specific indication or to fulfill a niche or to achieve a particular microbial effect.
Right.
It was just, we can put this in a yogurt and keep it in the fridge. Let's see what it does to IBD. So no surprise then that they're not very effective.
We can scale this up in a huge fermenter, and it's easy to. So when did you start to get interested in the microbiome?
It's about 2004. There was
Did you take a probiotic?
I didn't take a probiotic, but I suppose what I'm saying is coming into that, I suppose I came out of medical school interested in paediatrics, and then along the way I fell into paediatric gastroenterology and got interested in that as a specialty, and I suppose became quite passionate about looking after patients with inflammatory bowel disease. And I was very aware that we were using exclusive enteral nutrition to treat inflammatory bowel disease, but probably at that point, and we're probably talking around 2005-ish, I don't think people were fully aware of how that did its job, how it worked.
Sorry to cut you off, but what was the genesis of EEN? Actually, sorry, what is EEN?
Yeah, so we should probably start there.
Yeah.
So EEN is exclusive enteral nutrition, and it describes a usually 6 to 8 week therapy course of a liquid-only diet, so with no other solid food, that we treat patients with Crohn's disease, and through taking that, we can drive the majority of them actually into clinical remission. So the data probably suggests about 4 out of 5 patients, pediatric patients, can go into clinical remission with exclusive enteral nutrition if they take that alone for 6 to 8 weeks.
Wow.
So it was first sort of arrived in pediatrics in the sort of 1970s, but has kind of steadily increased in popularity and use as a therapy from the sort of 90s onwards, and it's now accepted as a mainstay of our therapeutic arsenal, and it's probably the first-line induction treatment for pediatric Crohn's disease. Wow. It's also becoming much more popular in adult Crohn's disease now, although it is a therapy that's very cumbersome. If I asked you to just take a liquid-only diet for 8 weeks, given all the social aspects of life, your friend asks you to go out for a meal, or you want to have a drink or something like that, then no, that's off. You are on your milkshakes, breakfast, lunch, dinner, snacks
tough. Every
day and we make people do it for 8 weeks rather than 6 weeks, because probably the longer you take the course, the more effective it is.
So we'll come back to EEN and what people drink to make sure they get the right nutrition and how it's working and so on. But can we just go back a step further and talk about IBD and what IBD is? And
we can start wherever you like.
Yeah, let's do that. Let's go back to the fundamentals.
Yep.
So IBD.
So IBD, inflammatory bowel disease, basically describes a chronic, by which I mean long-term condition of inflammation within the gut. There's 2 main types of IBD. There's Crohn's disease and ulcerative colitis, and they're both slightly different, and we'll come on to that in a second. But I suppose if you're thinking about what's inflammation within the gut, well, if you had a spot on your nose, it's red, it's tender, it's sore, you can see that there's inflammation there. And in IBD, you have a similar amount of inflammation, but around the gut in different places, and where that is impacts on what the symptoms are of the person who has that condition. And for reasons we don't fully understand, when you get IBD, that's then part of your journey forever, in the same way that when you get epilepsy or diabetes or whatever, that label is associated with you forever. So currently, and I need to lean on Billy Connolly here. So Billy Connolly, when he was given a Parkinson's diagnosis, his doctor said to him, "There's no cure." And he said, "That's a terrible thing to say to people. And don't say that, because it takes hope away. It's better to say there's no cure yet, or we're still working on a cure." And that's the case with IBD.
Right.
There's a lot of research, a lot of interest in IBD, what causes it, how we might treat it. But right now in 2022, if we give someone a diagnosis of inflammatory bowel disease, we're giving them that for the rest of their life. And we're saying this is a part of you and your journey. And we have lots of good treatments for IBD to drive the disease into what we call remission, which is where we switch off that inflammation, the gut heals, the symptoms go away, but we don't have any curative therapies. Okay, so
understood.
So that inflammation, so in Crohn's disease, that inflammation can be any part of the gut from the mouth down to the bottom, and can skip areas where there's healthy and then unhealthy throughout. Sometimes that can cause narrowing of the bowel. Sometimes it can cause abnormal connections between parts of the bowel. Ulcerative colitis, on the other hand, just affects the last part of the gut, the colon. Okay, the symptoms are affected by, or the symptoms are influenced by where the inflammation is in the gut. So if you've got inflammation in the last part of your gut, it tends to cause diarrhea, blood in the stools. Higher up, it might cause abdominal pain because it's your gut and it's got a job to do, and that inflammation's around there and getting in the way, and also it speeds up things going through. Sometimes it can lead to malnutrition, weight loss, loss of energy. In my population, pediatrics, delay in puberty, delays in growth and things like that. So it's pretty significant and serious conditions.
You mentioned pediatrics. Why do you think people are getting it earlier in life and some people are getting it later in life? What's driving that, do you think?
So it's a really great question. And so we're definitely seeing more inflammatory bowel disease year on year than we were seeing before. And every time anyone looks at that in the West, they're able to kind of describe that the curve is increasing generally. But we're also seeing in pediatrics, we're seeing it getting younger. So it's affecting patients who are younger. When I started doing this, it tended to be teenagers who came through the door. Increasingly, it's kids who are in the primary school ages. And
really?
Yeah, and
Goodness me.
Even more than that, we're seeing more and more children who are under 5 coming in with inflammatory bowel disease. So it's now it used to be when I started my career, it's not that long ago.
Wow.
It was really rare to see somebody who was under 5 with inflammatory bowel disease, and now we have a small cohort of them, and it's not unusual to see a new one every year.
I mean, I can't remember that much from my medical school days, but I can remember, late teens, early adulthood, sometimes early teens is when people would first be diagnosed. I'd never heard of less than 5.
No, so it's changing a lot.
It's incredible.
And
why is that?
So why is that? Yeah. Great question. So our genetics hasn't changed over that time. Our epigenetics, which is about how our genes are switched on and switched off through processes that can influence them, might have changed a little bit over that time. And those two might influence how our immune system works and how our immune system recognizes the bacteria that are in the gut. Probably year on year, the bacteria that are in our gut are changing. So I suppose if you compare somebody who lives in a more traditional lifestyle in Africa against someone who lives in the West, you'll probably see they've got fewer bacterial species within their gut. What we
in
call
the West?
In the West, yeah. So what we call bacterial diversity. And that's probably linked to the changes in our dietary patterns over many decades. So our food sources have become less complex, more convenient, probably less orientated towards fruits and vegetables, more towards, I forgot the word for this now.
Non-digestible carbohydrates.
So non-digestible.
We're not getting enough fiber.
Yeah, exactly. Yeah. So our whole way of eating as a species has shifted. And probably our ways of being associated with each other and being connected to each other as a community have shifted. Our exposure to antibiotics has changed. We're delivering more babies by cesarean section. So lots of things within society, not any of these is individually causative, but lots of things have changed for us as a species over the last 100, 150, 200 years that have fundamentally transformed our biology and how we are colonized by bacteria and how we interact with those bacteria. And that's probably set up the right conditions for inflammatory bowel disease to happen in particular individuals. There will still be people who will get through all that and live through a whole life and never get inflammatory bowel disease. But there are people who for some reason, the setup of their genetics, their immune system, their baseline bacterial, there's very limited data on this, and then something comes along and sets them off.
Triggers that.
Yeah, I call that the Humpty Dumpty conundrum, because that's when once he falls off the wall, you can't put him back together again the same way ever again. But based on doing that, you then drive yourself into inflammatory bowel disease. That might be a course of antibiotics. That might be an infection with a Campylobacter or a Salmonella. That might be you've gone to Tunisia on holiday, and anecdotally, you've heard all of these things come to you in clinic where he was fine and then he did this and then this happened. But similarly, again, I would reiterate, lots of people go to Tunisia or have antibiotics or have an infection.
They don't get IBD.
And they don't get IBD. So that's the part that's difficult for us to explain.
Super interesting. Some of the triggers you just described there are also similar triggers to people that have psoriasis, for example, and they start to see the plaques for the first time. So maybe there's just something to do with the interaction between the microbiome and the immune system that's triggered by something. And in some people that produce a problem in their gut, in others it produces a problem with the skin based on probably their genetics.
Yeah. So it's all about setting up your immune system to respond in an appropriate way to something, whether that's your own tissue in a kind of proper autoimmune process where you're recognizing your own cells are foreign, or recognizing something that's supposed to be tolerated, like the bacteria in your gut, and recognizing that as foreign and causing inflammation.
So if the immune system is recognizing cells in the GI tract as foreign, why is it that in Crohn's we have these sort of skips and it can appear anywhere in the GI tract, whereas in UC it's all confined to the colon? Like, are the two different things, or is it the same process that's happening? The bugs are triggering the immune system's attacking the body, or is there different immunology between the two?
So there's definitely different immunology between the two. There's definitely different bacterial changes within the two. So if you look at various papers, then they describe different upregulation of immune cells and different colonization with bacteria. But there's a lot of fundamentals that are similar in terms of what you're seeing there. You know, you're causing this chronic inflammatory process. Quite why Crohn's leads to skip lesions, quite why it likes the last part of the small bowel and the first part of the colon, I don't know. And I think there's interesting questions to be asked there about what's going on. You know, what's the difference between 2 centimeters of bowel where one part's really inflamed and the next part is perfectly fine? And I can't answer that part for you, but you know, it's a fascinating question, and I think understanding that. Similarly, ulcerative colitis, often you can see in ulcerative colitis, so it's a disease that is classically described as going proximally from the rectum upwards. So it's in continuity from the rectum for an amount of colon. And actually in adults, it's often just left-sided. In children, it usually involves most of the colon, if not all of the colon. But you will often see where there's quite a clear demarcation, where it's literally like going from night to day. There's inflamed ulcerative colitis colon and then normal colon above that. Wow. And what's that about? What's going on there? Why isn't it continuous? Why doesn't it affect everything? Or what's going on in that part? What's going on in that part that protects it? I don't know that.
Are there theories for that, like that people postulate, or is it more of a it happens and we'll figure it out at some point?
I think probably the latter.
Probably the latter, yeah. But so over the course of your career, then, how has the relative importance or the perceived importance of the microbiome changed? You know, going back to your first interest in 2004.
Yeah.
Like, were you one of the only people that was interested in the microbiome and gastroenterology?
I mean, I think I'm kind of lucky because I got interested in this. So as I say, I cut off that story to talk about what IBD was. But in about 2004, I kind of realised that there was people who were starting to talk about gut bacteria, about probiotics, about colonization. You know, at that time, I probably hadn't quite decided between being a neonatologist or being a gastroenterologist. And neonatologists look after very sick infants, and not a lot of them, that's not true, but some of them who are the most fragile and most premature will get a condition called necrotizing enterocolitis, which is a bit like a sort of short-term severe IBD that burns itself out. So it's got very similar features in a lot of ways, and it's certainly driven by, there's definitely an association with bacteria in the gut and colonization of the gut and the introduction of foodstuffs to these premature babies. But it's also a very different process. And I got quite interested in that, and I got interested in this emergence of probiotics and whether this was going to, there was a lot of buzz about how it would start to change things and make new therapies available. And that didn't really play out, but it kind of sparked my curiosity. And then I had an opportunity to go and do a PhD looking at what was happening in gut bacteria in inflammatory bowel disease. And I did that with Professor Georgina Holt and Professor Imad El Omar at Aberdeen, University of Aberdeen. And when I started that project, the way that you would describe the gut bacteria or the microbiome, so the microbiome describing all the bacteria that live with you, was to basically clone individual strands of DNA into different E. coli and grow them up on lots of plates. And the more plates you did, the more bacteria you could sequence and find out what they were. And so you could do this on 100 different plates with 100 different bacteria and then get them all. And it was essentially it was a very slow and laborious and challenging process.
Was that the state of the art?
That was the state of the art.
That was the state of the art at the time.
When I started my PhD in about 2009.
Wow.
But during that period, there was the emergence of this thing called next generation sequencing, where instead of putting all those strands of DNA that relate to all the different bacteria into E. coli cells to grow them up, they bound to little beads and dropped into a little well on a big machine. And if you paid enough money to get enough of these wells sequenced on a big machine, you could sequence the microbiome in a kind of almost in a single step, not quite in a single step, but compared to that previous method. And you used to be limited by how many E. coli you could grow up on plates, maybe 100. And then you were limited basically by the budget of how many little wells you bought on the sequencing machine, which was called sequencing reads when it comes out the other end. And so you were suddenly going to 30,000, 50,000, however many, And I think that's where the game started to change, because you suddenly had a way of being able to do this which was quicker, more efficient, more detailed. You were getting much deeper sequencing of what was going on, and it started to take over really medicine actually and science, and you start to see these big papers coming out that are describing what is and isn't going on with the gut microbiome. And I suppose along the way people got very interested in this concept of microbial therapeutics, which is, okay, we're describing this thing. We know it's important. We can see that there are 300 to 400 bacterial species in someone's gut. We see that there are differences in ups and downs depending on what disease state you're describing. How do we actually harness that? How do we change that? And I suppose, to me, I think we're still in that revolution. I don't think I think it has taken off, but I don't think it's quite gone full logarithmic acceleration phase yet. And the excited part of me is that I think that's still to come. And I think we will see big changes to, for instance, inflammatory bowel disease management, but maybe many other human conditions through the advent of microbial therapeutics.
So going back to the next generation sequencing element, so based on what I understand, it was and is a game changer, because instead of having to manually plate out 100, say, and that doesn't even capture the 300 to 400 that's in there.
Yeah.
You're taking a sample and doing some work on it, moving it into the next generation sequencing technology, and that allows you to profile everything that's there to a certain level.
Yeah.
Essentially.
Yeah.
So it's revolutionary. And so how did you become aware of it? And then how did that influence your PhD and then like the work that you were doing moving forward?
So I read a paper, and it had described having done this in another cohort, and I presented that to our group, I suppose, and I said, we were all getting set up. I'd been collecting biopsies from children with IBD at their first presentation, and we were collecting those and putting them in a freeze, and we were doing various other things. We were trying to grow particular organisms from them. We were doing some PCRs for specific organisms, but we had this growing cohort of paediatric colonic biopsies from the onset of inflammatory bowel disease. And
those samples must be very valuable, right?
Well, they were, yeah. It's quite a while now, quite a while ago now.
Yeah.
But the concept was, if we want to understand this thing, then surely we need to go to the first opportunity, because if you look at somebody's gut bacteria after they've had the IBD for 5 years or 10 years, or they've had gut resections, or they've had various treatments, then that's going to be different. It's going to be influenced by that. Whereas we thought, well, if we could go to the very beginning of the disease, then what are we going to find out from that? And actually, subsequently, other groups, there's a study run from Canada called the GEM study that has taken that idea a step further, which looks at healthy first-degree relatives of people who've got IBD, to follow them through, because if you follow enough of them, then you can see them as they start to develop IBD. So you might be able to even get those changes before it happens and as it happens. So we're all excited to see what exactly comes out of that.
Is that running like kind of as we speak? It's been
it's recently closed recruitment, I think, and they have published a couple of things, but they haven't published big killer data on exactly what's going on there. So we're all excited about that.
And are they measuring sort of stool samples, biopsies, it's blood, everything?
So it's stool samples for their study, and that's because it's hard to get biopsy samples without doing an endoscopy, and it's hard to do an endoscopy without all of the paraphernalia that goes with it, and in my population without general anaesthetic. So that's challenging. Okay, so we got this cohort, and I said, we're going to do this cloning and sequencing thing, but actually this next generation sequencing is arriving. Could we look at doing this? And we didn't really have the costing for that, but we put in a small grant. We got about, I think, £35,000 from a great charity called KICRA, which is Crohn's and Childhood Research Association. So they're specific to paediatric research, and they funded the next generation sequencing, and we did that on a cohort from that study, and we published that. And I think we were the first in the literature to publish on what the gut microbiota was in biopsies from children at their first presentation with IBD. So,
wow. And did you see any changes in the microbiome on the biopsy versus the lumen? And is there a difference?
So we didn't specifically study that so this was called the BISCUIT study. It was the acronym that we used for that study, and we didn't specifically look at stool against biopsies, and we did that for specific and pragmatic reasons. And this is one of the challenges about clinical science: is you've got to be a great pragmatist. You would like to sit down and devise everything to great detail and say we're going to look at this and this and this in this context. But then as soon as you take that to the real world and you start trying to think about how you're going to apply that, then you immediately meet challenges. And the first challenge I met with thinking, well, we'll get stool samples and we'll get biopsy samples was, well, these children are coming in for a diagnostic endoscopy for their query IBD, or in some cases controls who don't have IBD. They're arriving in the hospital for bowel preparation for overnight. So they pretty much as soon as they're admitted, someone gives them something that makes them poo more than they normally would. So the first poo that you're going to get out is going to be more watery. It's going to be affected by a faster transit. It's not reflective,
it's not representative
of what their stool would be normally. So we quite quickly realised that we couldn't do that in that study, so we had to focus on the biopsy samples. But other people have looked at stool against biopsy, and they're two distinct ecosystems. So there's a lot of utility in stool because it's very convenient, and you can sample it without the need for an endoscopy, and you can sample it serially, but it's not necessarily the same thing as what's happening at the gut mucosa. And again, my analogy for that is like the beach and the ocean. You know, there will be things that you'll see in both environments, but there's also going to be things that are unique to both.
So are we missing a trick, so to speak, with all these microbiome studies that we're doing, sort of drawing conclusions between healthy people versus controls, healthy people and controls versus disease population, insofar as it's all stool-based microbiome analysis?
Well, we might be. I think it's very much got a role. And I think, you know, if for instance, so we used disease controls, if you like, for that study as an example. So we used children who were having a colonoscopy for another reason who didn't turn out to have inflammatory bowel disease. But the threshold for getting a colonoscopy under general anaesthetic is not insignificant.
Sure.
So these are kids who've got other symptoms and probably have something like an irritable bowel syndrome, or some of them had a polyp or something, you know, something different to inflammatory bowel disease. But they're not the same as healthy children who are in a play park, you know, and that's an important distinction. But you can't take healthy children who are in a play park, or you can't take healthy, you know, men and women who work and have jobs and who are not affected by disease, and just take them in and do endoscopies on them for the sake of taking biopsies because it suits your biologic integrity, you know, your desire to get to the pure answer. So there's a compromise there, which is, okay, what's most important here? Is it sampling bigger cohorts? Is it sampling cohorts that are closer to healthy to compare against? Is it doing different time point analysis? Or is it saying, no, I'm going to be so stuck on the fact that I want biopsy samples because I know that that's different, that I'm going to limit everything to that? So that's the pragmatic thing again, isn't it? You know, it's about how do you choose? And I think the truth is there's a bit of both that's needed. You know, I think if and when we can sample the mucosa by biopsies and an endoscopy, we probably should. If we can't and we need to do, and particularly for longitudinal studies, this is really critical. You need to be able to do it quicker and easier, and so therefore collecting stools makes sense. Another thing about stools that's helpful though is with a stool you can start to correlate the results that you get from that with an inherent property of that from the fecal calprotectin. So fecal calprotectin is a protein that can be used as a biomarker of inflammation, and we use it to help us decide whether someone might or might not have inflammatory bowel disease before we do endoscopies.
So if it's raised, then you've got a higher index of suspicion.
Yeah, so if you do 5 stools from someone and you look at what happens to their bacteria over that period, and you also look at what happens to their calprotectin, then you can actually infer something from that. You know, lower calprotectin means less inflammation, means you're controlling the disease better, and what's the bacteria changing in response to that.
And I guess you could maybe go one step further and look at the Bristol stool score as well, as an even like higher macroscopic, you know, analysis of transit time.
Yeah, so you're getting to another point here, which is probably important and probably underappreciated in a lot of studies, which is if your gut is inflamed, your transit time, which means basically the speed it takes for something to go through your gut and come out the bottom end, is faster. And so if it's faster, the bacteria are going to be changed in, you know, by that. So how do you account for that, and what does that look like? So there's a lot of complexity in trying to understand and devise microbiome studies.
And I guess there's this big question, which is, are the changes in the microbiome driving or are part of the disease pathogenesis, versus are they a consequence of whatever is going on?
Yeah, it's chicken and egg.
The chicken and the egg.
Yeah.
And I was going to ask you specifically, because we've talked about it before, and it's a toughie. What's your personal view on, you mentioned, you know, you've got this journey. No IBD, healthy, Humpty Dumpty conundrum day, where they fall off, and then you've got post diagnosis and symptomatology. So I guess if there was some way of figuring out before they fall off that they're going to, then you can maybe intervene sooner. So do you think that the microbiome changes are the cause or the effect of the inflammation that's happening in the gut?
It's a really great question. I think they're causative, but I think they can become the effect as well. And I think that's probably, you know, one of the hypotheses that our group had, and I think we published this quite a long time ago now, about 10 years ago, was this idea of, so there's this word called dysbiosis, which basically means that your gut bacteria are imbalanced, and the net effect of that imbalance is inflammation. And
Professor Holt will say she doesn't like that word.
She doesn't like that word.
She doesn't like it anymore. No, I don't think so. No.
Well, you can ask her when you interview her.
I will do, yeah.
But, you know, dysbiosis is this word that's been in vogue for quite a long time within this sphere. And in inflammatory bowel disease, it's thought to be an IBD-type dysbiosis, where there's reduced bacterial diversity, there's increase in particular bacterial populations and reductions of other ones, and the net effect is inflammation. And we kind of postulated that maybe the Humpty Dumpty event is something comes along and it drives you into dysbiosis. And perhaps for you or I, if we go to a barbecue and we eat an undercooked chicken sandwich and we end up with Campylobacter and we spend 5 days in the toilet and we're not very well, we've gone into dysbiosis. But we then come out of it again. So it's like an unstable dysbiosis where your body can right that and fix that problem. And then you come back out of that again.
Sorry, Richard, that fixing element, what happens there? Does the existing ecosystem just sort itself out a little bit and just push out the Campylobacter, saying we don't want you here anymore?
It's a great question. I don't think we know enough about that, and I think that, you know, it's a really interesting area to get into. Yes, the immune system is going to be involved in some way in terms of clearing the organism and setting things up again. Yes, you're going to have a period where your diet has changed and then changed back again, and most people don't immediately go from having a severe bacterial gastroenteritis to eating exactly what they ate again, you know, the day afterwards, kind of thing. So there is a process of returning to your own physiology, but probably there is a process where your bacteria redeem themselves somehow, and that's unknown. There are some hypotheses that the appendix plays a role, and might be, you know, that it might be that the physiological role of the appendix is to store bacteria so that when you have something like this, then it can say, oh, you need these now, and sort of spill them out into the gut lumen and say, here you go.
Wow. I'd never heard that before.
There you go. So
this
whole conversation was worthwhile.
Oh, absolutely. I've learned so much already. I knew I would. I was really looking forward to this. On the appendix then, lots of people every year have their appendix removed. Are they, based on objective evidence that we've collated over time, more likely to become infected with a pathogen, or are they more likely to get IBD? Like, what do we know about people that have had appendicectomy?
I believe appendicectomy is protective against ulcerative colitis. So there is actually, that seems to benefit you. I hope I've got that the right way around, but I think that's the case. You put me on the spot there with that one.
Sorry.
But,
we can pull it up. We can do a Google.
But
I'm not saying Google's better than you, but
it doesn't seem to be that that's a major problem for most people. And like a lot of these things, whenever you do a study to try and understand what the impact of something is within medicine, there's always confounders that come along there that play into that. So for instance, and I've mentioned that Campylobacter or Salmonella infection increases your risk of IBD. And so you can play that out one way, which is that process starts the Humpty Dumpty thing that drives IBD in the first place. Or you could play it backwards and say people who have IBD are more likely to be susceptible to Campylobacter and Salmonella infections. It's got nothing to do with causing their IBD. It's just that's a marker of the fact that they're that person, And
sense.
So if you do the same thing with going back with appendicectomy, you might well find that there are other reasons why people had appendicectomy that are actually the true cause of whatever it is that you then associate with it 5-10 years down the line. So I'm by no means expert in bacterial reconstitution after a gastroenteritis episode, but it's a fascinating subject.
do you think that, and this is just a really blue sky type thing now, relating to diarrhea and travel, you could collect stool samples from people who live in the area you're going to, who are exposed to the microorganisms that live predominantly within that geography.
Yep.
Go through the process of screening for pathogens that are really nasty, putting it into a capsule or a tablet, and then giving it to people before they travel to sort of condition their microbiome to what's coming. Do you think that they would have less traveler's diarrhea, or is that pie in the sky?
You might just give them traveler's diarrhea.
Well, that was the thing I was thinking as I was
That might be
describing
it.
it to
You might have just caused it.
You might have given them the diarrhea. So it might be the
new
bugs.
diarrhea pills.
That's it. I don't think that will sell very well.
No, maybe
not.
No.
But
it's hard. It's hard to know. It's hard to know. And I think there's a kind of fundamental thing there, which is, and this is, I'm sure we'll talk about, fecal transplant or where we've gone with fecal transplant. But
for sure,
there's quite a lot of interest in how fecal transplant or taking stool and the bacteria from stool from one person who doesn't have disease and transplanting that into the gut of another person who does have disease. Predominantly, there's two indications really. There's Clostridium difficile or Clostridioides difficile. It changed its name a couple of years ago, I'm sure you know, and ulcerative colitis are the two things that people are most interested in. And in ulcerative colitis, there's probably a signal that pooling donors together is beneficial. So people who have actually done not just one donor into one recipient, but have actually taken multiple donors into one recipient, seem to do a little bit better. And I suppose I remember seeing a study from Australia presented at a conference about this, and I asked them about how they think about or avoid friendly fire between those communities, because you have got communities that are all set up individually to live in a person, and you've just thrown them all together and put them into another community and said, here, get on, and kind of hoping that causes peace. But how do you know that it doesn't just cause further warfare? And I suppose that comes back to your question about the traveller's diarrhea pill is you might well have a balanced microbiome from one individual who lives in a certain area and eats certain food, but if you give that to another person, there's no guarantee there that they're going to tolerate that the same way, because they're not set up the same way, their diet's not the same, their immune system's not the same, and it might well cause the diarrhea that you're trying to prevent in the first place.
Quite possibly.
But it might not, and that's why this science is quite complex and exciting, is that the answers are not straightforward.
That's one thing that's for sure. Just over the course of this conversation, there's still so much to learn, and so much benefit for patients on the hopefully not too distant horizon. Once we start to unravel and answer these questions, like when to intervene in patients with an IBD family relative or whatever.
Yeah.
And so let's go back to the IBD and the sort of studies, the GEM study. Do you think that there might be a signature in their microbiome which is consistent across patients, even if it's just reductions in diversity, for argument's sake, relative to an earlier time point, that have some sort of reasonable predictive value of them going on to develop IBD? Do you think that's where we're going to get to, or is that too simplistic a view?
It would be great. It would be great if that was true. I suppose, and again, it is blue sky thinking here now. I don't have data to support this, but I probably think that the more likely thing is that people will go from a microbiome that is okay and would be described as healthy into a kind of pre-morbid state where things are starting to change. And sometimes I suppose that might be quite acute, so we've used some examples of that, talking about bacterial infection, how that might change things, but sometimes that might be slow. And that might be a place where you can find a window where you're able to say, okay, for instance, your diversity index is dropping. I'm making this up now. This is not something for people to go and pursue, but your diversity index is dropping. So this is a time where we might be able to intervene and change that and stop a process. That would be great.
That would be awesome, wouldn't it? Strain X is dropping.
Yeah.
Strain Y is going up.
I don't think we're there yet, No. Although it is possible to send your stool in the post to someone, pay a lot of money for that, and for them to send you a report that tells you exactly what's going on.
We should talk about that. So what do you do then as a clinician? Someone comes in, they paid the money, they've got the 16S profile here. They come in and they go, "There it is, doctor.
Yeah.
What do I do?"
I prefer it when they come and ask me whether this is a worthwhile thing before they spend their money on it. And in that case, I tell them that they shouldn't spend their money on it. And when they come having done it already, I generally say, it's hard for me to tell you what this means. And there's lots of reasons for that. And I seem to be a bit of a conduit for this, where other professionals will say, my patients come to me with this report and I've received this, so what does this mean? And so I have to give this answer quite a lot. There's lots of reasons, not least that if you actually take a stool sample and you send it somewhere at room temperature, you're not controlling that environment anymore, and that's changed. But also that, as someone who's research active within this whole sphere, I don't know what a healthy microbiome is for an individual. I can probably tell you some aspects of what a microbiome looks like for a group of healthy individuals and how that compares with another group of individuals. But as I said to you before, everyone's different, and so your gut microbiome is unique to you as a fingerprint, or as your DNA sequence, and it's pretty specific to you as well. So you might well have James McElroy bacteria in your gut that you get on fine with that would cause me a whole load of trouble, and vice versa. So it's really hard to say, okay, now that the parameters within this report mean that these populations are low and this should be changed, this is a bad thing, because for that person they might not be. And I do think we need to get there. I do think that as a clinical community, right now, I suppose I said 15, 20 years, however long into this thing, if we think about the advent of next generation sequencing in sort of 2009, 10-ish, we're probably talking about 12, 13 years into this gut microbiome era. It's still impossible for any clinician, certainly in the UK and probably most places in the world, if not everywhere in the world, to take a sample from a patient and send it to a lab and have their microbiome analysed and have a report come back to them that means anything. This is still the sphere of scientific experiment within university laboratories on a kind of single cohort or single patient experience. And so if we're actually going to do microbial therapeutics and be able to say, okay, for instance, patient has ulcerative colitis, we're going to try a fecal transplant on them for clinical purposes out with the sphere of a clinical trial, we're going to have to be able to address that at some point in this journey where we can actually say, okay, Mrs. Bloggs has come along. She has ulcerative colitis. She's got active disease. We're thinking of a fecal transplant. We're going to look at her microbiome and see whether she's a candidate for this. And then we're going to do it. And then we're going to see whether it's worked or not, or with C. difficile infection or whatever. But that doesn't exist right now, and we will need to get there. So I think there will be a need to start to understand these things enough that we can do that, and we can deploy these tools as clinical tools and not just academic tools. But we're not there, and so save your money.
Save your money, there we go. But on the IBD front and fecal transplantation, let's jump into that now. And I'm conscious we need to go back and talk about EEN and kids too, but feel like we're there, so let's go for it. So fecal transplantation, the movement of microorganisms from a healthy donor into the intestinal tract of a recipient, tended to prevent or cure disease. In C. diff, there's been a large number of studies, nice guidelines. It's established for the prevention of recurrence. UC, sounds like there's 6 studies now.
Yeah, there's 6, I think.
6 RCTs published.
As of this week.
Rosen, Costello, Paramsothe, another Australian study.
Yep.
And then there's
the Israeli study, and there's an Indian one just published this week.
An Indian one as well. So in your opinion then, like, are we there now with UC? Like, is this real? We've seen 6 studies, but
we've not, out of those 6 studies, and I'm not as good at saying this study said this study said that, this study said the next thing. My brain doesn't work like that for some reason, so I can't immediately say here's what the risk ratio was for that. But the messages are that actually, although there are studies and there are randomized trials and there is data there and there is a support for this, they all took slightly different approaches in terms of what the control was, about how the FMT was delivered, in some ways about how they prepared the FMT, about whether or not they were pooled donors or not pooled donors. You know, the most recent 2 that were published also did dietary manipulations. One of those did dietary manipulations on the donors and then on the recipients.
Oh,
and
interesting.
The most recent one from this week just did the recipients, and they went on to a kind of anti-inflammatory diet to try and support engraftment. And some of these things are not trying to understand what the hypothesis was and what the thinking was can be a little tricky about dietary manipulation. And I suppose whenever if you go out with an umbrella and red socks on and your hair doesn't get wet, was it the umbrella or the red socks?
Right. I hear you.
And so trying to ask complex questions can be quite tricky when you're pooling things. But I suppose how I would respond to that is there's a signal. Okay, there's definitely a signal that ulcerative colitis can be improved by fecal transplant if you give the right transplant, whatever that means, to the right person, whatever that means, by the right route, which is probably colonic. Okay,
and the right number of times.
And it might be lost over time as well. So
fascinating.
I think there's a video on YouTube, and I feel sorry for this guy, and it would be terrific if you could see this, because this is me apologizing to him. But there's
I thought you said it would be good if we can pull it up, because we could.
Well, you could if you want, but there's a guy on YouTube called Michael Hurst, and he has a video called DIY transplant for DIY fecal transplant for ulcerative colitis, and he shows you in kind of both very clean and very graphic form, how to administer your own fecal transplant to treat your ulcerative colitis. Now, my stock recommendation to any of my patients or anyone who asks me that is, you wouldn't do a bone marrow transplant having seen a video off YouTube. And so you shouldn't do a fecal transplant for the same reason.
Right.
So, and actually it's a really helpful thought experiment to think about bone marrow transplant when you think about fecal transplant, because they're actually the same thing in a lot of ways. You have a donor and a recipient, and those 2 need to match. You have to do prior conditioning to change the environment so that the graft will actually go in and embed and work. And then you need to follow that through carefully to ensure that it's still done what it's wanted to do. Okay? And I think those are exactly true of fecal transplant. But we don't know what the parameters are quite yet. So
can I just push back a little on the preconditioning?
Yeah.
For the fecal transplant, what element of preconditioning do you think is required?
So
is it the bowel prep or an antibiotic?
I don't know. And so people have tried different things. So I suppose if I throw the things that people have tried to use, people have used proton pump inhibitors to reduce acidity, particularly when they use nasogastric fecal transplant. They've used loperamide to slow the gut to try and keep the transplant in place longer in the hope that it will colonize better. They've used preconditioning with antibiotics in the hope of opening up an ecological niche to try and help colonization. And of course, I suppose dietary manipulation, either for the donor or the recipient, can be considered preconditioning, or maybe even post-conditioning, depending on how you do it and when you do it and what that looks like. So you could immediately see how many parameters there are that are shifting, and yet here we are, 6 randomized controlled trials, which have all taken a slightly different approach to this.
Absolutely.
So how do you start to pull it apart? So what does success look like, and what does that mean? And that's still difficult.
Do you think that, given I'll call it heterogeneity, although it's not, by the dictionary what we're talking about here, but given that in the Dutch study, the Rosen study, there was 2 IMTs or FMTs, and in one of the Australian studies, the Paramsothe, they did like 40. They did 1 colonoscopy and then self, and there was the anaerobic processing.
Yes, this is a sort of treatment duration. Yeah.
all the methods of prep, all the things that we were saying made them difficult to compare. But on the one hand, I hear what you're saying totally, that it's difficult to compare because the methodology is different, the patient population set are different, the endpoints differ. So the Moriarty study had a really tough endpoint, I think. Is there some, you know, as a clinician scientist, can you look at all of that and go, okay, a lot of difference, but the signal? Yeah, no, there's a signal every time. So this concept of moving microbes from one person to another in UC there's something there, right?
Undoubtedly. I mean, I'm not disputing that there's something there, but I suppose I want to understand. I want to understand when it works, how it works, because that's how we move forward.
Patients.
Yeah, that's how we move forward. Right. You know, and this is where it gets a bit interesting, isn't it? Because if you give FMT to UC patients and 100% of them went into clinical remission and they stayed in clinical remission, if this is a thought experiment, okay, then it wouldn't matter that much.
No,
it wouldn't matter that much.
I mean, that would be a wonderful thing
because it's effective, you know. And everybody pats themselves on the back, and we just crack on and we do this. And maybe in a few years' time, when we've cured all these people of UC, we think, I wonder how it works. Can we refine that further? But that question is not as pertinent as it is right now. But that's not what we're seeing. We're probably seeing efficacy rates of somewhere between 25 and maybe 60%, depending on which study you look at, against placebo rates, which are also not insignificant. You know, so this, irrespective of what placebo you give, we are seeing some placebo response in most of these studies as well. And so we need to understand, why is it working in these people? You know, I think it was the Maedi study that had a super donor that seemed to be most effective.
Donor B.
Yeah, that seemed to be most effective.
Donor B,
in terms of driving people into remission.
I can say from an industry perspective, that Donor B study catalyzed the formation of many microbiome companies that said, well, we're going to look at these FMT-IMT studies. We're going to look at the sequencing data, pre and post intervention, and if there's a correlation or a cluster towards certain strains in the phenotype of interest, like clinical remission, that's a drug candidate. Yeah. Now, as far as I'm aware, we don't have any asset in late stage development that's a defined consortia for UC. And I haven't seen the Donor B phenomenon explained by anybody, and I'd imagine they've analysed everything in that study. I've not seen it really replicated either in any of the other sort of UC work. So what was that? Was that a real thing, do you think? Do you think there was a super donor, or?
I think probably calling it a super donor is maybe being too strong.
I feel like that. In fact, to be honest with you, Richard, I think that anybody who passes the screening, which is as rigorous as it is, and donates every day for a few months, you could probably call them a super donor, right?
But they actually are willing to do that.
Because they're willing to do it and they meet all the criteria. I mean, we'll do an episode on what makes a good donor. Is it someone that comes in every day? Is it someone that has a really massive output?
And we actually, I've been involved in the Stop Colitis Consortium as well, that did fecal transplant as a pilot trial in adults across Glasgow, Birmingham and London. And we went through a lot of these questions in the trial design. And there was a point where we were saying, what are our exclusion criteria for donors? Do we want to exclude people who have obesity? Do we want to exclude people who are smokers? You know, do we want to pool our donors together and do a super poo, you know? And we kind of settled on trying to be as simplistic as we could, because we didn't want to fall into the trap of believing we knew something up front and missing the opportunity to find something by accident. You know, serendipity still got a huge role to play in scientific discovery. Right. And what you actually want, where this field is going to go, I think, is once we have enough high quality studies where people have done pre and post microbiome and associated that with, you know, whatever markers of remission you like, and looked at longevity and everything, and compared donor and recipient and tried to figure out what matching looks like and which organisms are important, then we'll probably start to understand, okay, this is these. I don't think there's going to be one bacterium that you can pull out of all this and say this is the cure. I don't think that's right. I think what we're going to find is particular donors have an open niche that can be colonized by particular types of organisms. Sorry, I'm bashing my microphone now. and that will differ in different people, and it might even be that the space that's open up is different and relates to different phyla of bacteria or different different classifications of how those bacteria work within the gut in different people. So
on the space and niche element there, then, is that potentially why the pooled product seems to be better than the monodonor product insofar as there's more shots on goal?
Yeah, exactly.
Kind of
And more shots on goal is a great analogy. Yeah, you if you're putting 1,000 bacteria in and not 200, or, this is where perhaps how you process it is important too. If the bacteria have survived long enough to get to the patient, then you might have a better chance of it doing something. And these things are all worth thinking about too. So,
I mean, we have actually published together in the past a paper that said pooling. I've got a very different view on that now for all sorts of different reasons, and that's fine. I think having an open mind that's amenable to change is good. But from a scientific point of view, then, we've talked about the shots on goal. Is there any other element of, if there's more bugs in there, you might get a bigger immune response? Like if there's more diversity, you might trigger the immune system in different ways, or is that not how it works in IBD, do you think?
Yeah, you might. And I suppose this is the thing that I probably my slight bias against pooled donors is twofold. One is, I think there is a theoretical risk, at least, that you could have what I call friendly fire between those donors' microbiomes, and you might, impart more pro-inflammatory state by doing that. I'm not sure that that's really supported by evidence, and I think that's probably maybe an anxious. Probably the second one is the scientific purist argument, which is the bit we need to get to, which is how does this work? When it works, is going to be harder to pull apart when you've put in 1,000 organisms and not 200. So trying to understand what the key players are and how they have performed and done what they do is going to be harder if you're using pooled donors than individual donor. And I suppose pooled donors as a concept is not just about a single treatment. So particularly if you've got longitudinal treatment, pooled donors might also mean that every time you come in, you just get whatever donor comes out the fridge or the freezer, so actually in stock colitis, we matched donor to recipient for their total treatment course.
Makes sense.
So they always got the same person. And that was for mechanistic reasons as much as anything.
But on the pooled element, surely if you're doing really robust characterization of the drug product before it goes into the patient, because you've got that data on composition, does it matter if it's come from multiple different people? Because it is whatever it is that goes in, and as long as
it might not. It might not. And I this is where we're getting into speculative science here, and we have to be very careful to not let that cloud our view and drive our direction. Because when you don't have data, you should try and find data. I've got good reasons to say I'm anxious about that. But similarly, I am, again, we go back to that word pragmatism. At my heart, I'm a clinician. And what I want is something that's going to help my patients, And if something's going to help my patients better with pooled donations and 1,000 bacteria in it versus a single with 200 in it, then I'm all in favour of that. And if it takes us longer or it's more complex to get to understanding how that has worked, but the net effect is I'm able to move patients away from stronger immunosuppression and towards microbial therapy and keep them well or for longer, I'm always going to choose that journey. That's an easy win for me. But it is, I suppose, what I would say in all of that is understanding that signal and getting to the disease biology is so fundamental, and we mustn't miss the opportunity to do that along the way. We shouldn't cloud ourselves to that, and we should be open-minded about what's going on and trying to understand. And as I say, I don't think it will be a single bacteria or a single group of bacteria filling a single role. I think that will vary between people, but we might be able to describe, 5 or 10 distinct things that are similar, that you say, okay, these are the characteristics that seem to be important across these people, and we've identified these groupings of, this set seems important, this set seems important over here.
The mechanism piece, which is so important, how do we make sure that we are doing the best work we possibly can to understand how these fecal transplants are working?
Yeah. So that's about characterization, isn't it? That's about characterizing everything as often as you can and as completely as you can. And so that's where, you know, we've talked about next generation sequencing already today. We kind of didn't talk about exactly what that is, but you know,
we can do that.
There's two variants, I suppose, to think about. There's amplicon sequencing, which is the kind of quick version, which is sometimes called 16S, where you sequence one particular gene out of bacteria and you use that as a barcode to describe all the bacteria in the sample. So then everything after that's inferred. And then there's metagenomic sequencing
Sorry, Richard, on the 16S, how does that work? Do all bacteria have this 16S gene?
Yeah.
And there's some elements that are ubiquitous across all bacteria, but some that vary?
Yeah, so all bacteria have a 16S gene, and it has both highly conserved and highly variable portions. And so you can line up PCR primers to do an amplification step against those conserved parts, and in between them, you'll get the variable parts. And through that sequenced product, you can compare that to an online database that says, aha, this looks like Staphylococcus aureus or whatever it is that you're choosing to look at.
That database, have they taken the pure culture and sequenced the entire?
Not always.
Not always.
Okay. And it depends on the database you
Not
use.
always.
It depends on the database
so
you use.
Limitations.
So there are always limitations about matching up against and you know, good old Donald Rumsfeld's unknown unknowns. You know, if you have a bacterium in there that nobody has sequenced or nobody has cultured before and it's not in the database, it's not going to match against that. You know, it might match against something that's similar to that, lower percentage value, but it's not going to match against that because you don't know what it is. Okay, so and that is something that's kind of initially kind of plagued this whole sphere, but I think with time we're probably recognizing that what we thought were unknown bacteria probably is shrinking, you know, and
interesting.
There've been concerted efforts to try and grow some of these organisms, which are quite difficult in culture.
Why are some bugs so difficult to grow?
I mean, I find that really interesting because they managed to get there.
Yeah, and they're here, happy.
Yeah, you know, they managed to get there
the best thing.
somehow from somewhere, and then they managed to sort of bed in and stay there and not be bothered too much about it. And yet there are scientists who devote their careers to trying to culture these organisms and get the right oxygen concentrations, the right temperature, the right, I'm not a conventional culture microbiologist really by any stretch, so
we're going to get someone.
That sounds like another podcast for another day.
Probably,
so,
probably.
But metagenomic sequencing is the other approach, where basically you take all the bacteria that are there in the sample and you just mash it up and you sequence everything, and then you put it back together in a computer again. So your depth of data analysis, your ability to look at not just what bacteria are there, but what functions they contribute is better with a metagenomic approach. But it's not always straightforward to do that. So again, this has got back to our previous discussion about stool versus mucosa. In a stool metagenomic, fine, you can do that quite easily because most of what's in a stool is bacteria. So the predominant DNA that's going to be in that sample is bacteria. So you're using all that sequencing for good effect on what you're interested in. But of course, if you take a gut biopsy from a human, surprise, most of that is human, you know, so 97%-ish of a gut biopsy is human DNA. And so if you're going to do metagenomic sequencing of that, you have to constantly sequence the human genome and throw it away to get to the bacteria that you're interested in.
So it's harder to get
more expensive.
It's more expensive.
Yeah. And of course, there are ways that you can, you know, micro dissect that and take off the mucosal layer and everything. But does that then mean you might be missing bacteria that reside intracellularly? And what's the significance of that? And are you missing a signal that might be there? You know, so there's a lot at play there in terms of thinking about which technique to use.
And in terms of the analytical toolkit more generally, then, what else do we have other than the next generation sequencing that could add value to these characterization studies we're talking about?
I mean, you know, I suppose I'm a clinician and not a lab scientist, and I have to be careful about that. And I think, you know, a lab scientist would give you a much more detailed view because that's their sphere of practice. But
you're interesting though, because you're, I think, quite rare insofar as you're at the cutting edge of the science because you're scientifically trained with your PhD, but you also see patients all the time, and you can help bridge the two. That's so important, because there's so many times you speak to someone, we've got this amazing new technology, it was an amazing idea, it's going to be so good, and then they bring it to a clinician and they just go, that's just never going to work.
Yeah.
Because this is how a hospital works. And these patients, by the way, they're people, and they're just never going to do that. Do you know what I mean? So I think it's really, it would be good to hear your perspectives on the toolkit.
So the toolkit, I suppose, the sequencing is really good because it lets us know what's there, and it does that in a kind of hypothesis-free way without the biases of things like culture. Because if you try and culture a stool, for instance, to try and get bacteria out of that and find out what's there, you're always going to find things that are better at growing will come to top. So E. coli, being a good example of that, grows really easily in most environments, and so it will grow first. And in doing that, it will outcompete other bacteria for nutrition, and it will, squeeze them down, and you'll not see them as much, So that's a good reason why using stool culture or other cultures is a problem, because you're not getting a kind of pure representation of what's going on there. The culture bias creeps in and starts to change that. But culturing bacteria is still helpful and important, because then you have a bacterium in front of you. You can look at that in its own right, in terms of, okay, what do we know about this bacterium and its cell surface proteins, about how it interacts with immune cells, about what its growth criteria and conditions are. Let's sequence its genome and see what genes it expresses, and what toxins it might produce. You might think about things like antibiotic resistance, which you could obviously do in a lab setting, but you might increasingly be able to do by genome sequencing. And so that's one example of how growing bacteria can still be helpful, and it's probably a bit of a dying art in this field because everyone's rushed over towards
the NGS.
Molecular sequencing. But in addition to the approaches of sequencing bacteria, there's this whole package of things called multi-omics, which basically describes all these different technologies that can be applied to different sample sets. My colleague Professor Kostas Gerasimidis, who kind of leads up our scientific group in Glasgow, he's a great fan of short chain fatty acids as a kind of marker of what the bacteria are up to. So we do those alongside our stool samples for looking at what bacteria are there, but also what are they up to and what does that tell us about their metabolic activity. You could look at what proteins they're generating as a sort of proteomic approach, or even what proteins the host is producing in response to that.
Wow.
Or
so much.
There's an infinite number of scientific approaches you can now apply to this. But the challenge becomes actually the size of these data sets is enormous, and the data analysis required to try and integrate them and to pull that together into a single question becomes very complex. But in there lies great opportunity to try and understand disease in ways that we've not thought of yet. So if you throw a multi-omics approach at something and catch all these different huge data sets, and you also have good clinical, and this is why my part becomes important as well, and where my expertise is probably relevant, is good clinical definition of who this person is, what they have. We talked earlier about, okay, they've got Crohn's in one part but not in the other part, so that might describe that as their phenotype.
Right.
What phenotype of Crohn's do they have? What does their blood cells and immune workup look like? What medications are they on? What the drug levels of those medications are? All of that part is as relevant as all the scientific toolkit to try and understand what's going on, not just in this person, but in this cohort of people.
Right.
And then let's throw a digital question at that. And that digital question might be, how do we tell the difference between responders and non-responders?
Based on the microbiome.
Based on all of that, and see what comes out.
And is this part of the, I don't know, it's a buzzword, but the AI piece, does that fit in?
Yeah, so that's why this is starting to change and starting to become very exciting. There's this new-ish concept. Probably someone in the field will say we've been talking about this for 20 years. To me,
almost certainly,
it's new. This idea of machine learning. So basically, that you basically have a computer that goes through all of that and tries to look for signal, and the benefit of that really is that the computer doesn't care what your favorite bacterium is, or how much effort or energy or expense you've spent on this part of the scientific process. If the signal's up here, it's going to show you that that's where the signal is, Right. And so, the purest scientists might say, well, you're kind of getting away from the core scientific principle of having a hypothesis and testing that hypothesis, and you're now just rolling into what does the machine tell us? But of course, the machine might point us in directions we haven't thought of yet and say, okay, the most important signal in ulcerative colitis is this one protein being synthesized up here. And if you can target that, then, so we might change the paradigm of disease.
Could be the red sock and not the umbrella.
Could be the red sock.
And the machine it doesn't have the biases that I guess we do. I suppose it's programmed by us, so maybe it does. But so are you implementing the machine learning into your work now?
Yeah, we are a bit, and I think that's the step that has come from, it used to be about bioinformatics, which is about transforming all those data sets into usable data that you can put into a spreadsheet or into SPSS or whatever and to do an analysis on. But as you pile on more and more data sets within this multi-omics sphere, you need to find ways of integrating those and still interrogating it. And that's where machine learning has come in, really. And that's probably our major use of it, is to try and integrate complex data sets and to try and answer, but it's all about both the simplicity of the question that you ask and also that question is pertinent.
And the quality of the data that goes in, right? Because I suppose you need the data to be true and valid for the signal that it picks up to be true and valid as well.
But you also need true experts in all aspects of that analysis. So the bioinformaticists that we've had who've helped us with our data set and these, machine learning experts, many of whom are bioinformaticists, that's a really sought after specialty within the scientific community right now.
Are there trained clinicians who are now getting into this expertise as well? Is it still more of like a basic science, bioinformatics, computer science type thing?
Yeah, I don't think, I feel quite strongly about this. I don't think that's our role. And I probably very specifically think that it's almost important. Like, a lot of clinicians do believe that they can just be a jack of all trades because they're quite smart people and they've gone on a journey and they understand the disease. But, these tools change very quickly. And I remember when we talked about doing my first next generation sequencing project earlier, and I remember distinctly the day that my data arrived back. Here I was, a kind of young registrar doing a PhD, keen on this, excited about this, £35,000 we spent on sequencing. The data came back. I excitedly downloaded it to my computer, and I thought, I can't wait to see what I've got back. Yeah. And what I got back was one notepad text file of 4 gigabytes of A's and C's and T's and G's and some little tags, and at that moment, it transformed my understanding of what this was all about to the point that, okay, I need someone who gets this and who can turn this into something that I can understand because I can't go there. And for a while, I entertained the idea of like, I'm going to teach myself to be that person because I want to be able to get into this, But if I'd done that in 2012 or whenever that was, in 2022, it's irrelevant. The tools have all moved on. There's different iterations. There's different processes.
Moved on a lot, hasn't it?
Huge, So let's specialists be specialists. Let's not pretend that the clinician's job is to be a bioinformaticist. It isn't. Right. The clinician's job is to define the clinical cohort and the clinical question and to make sure that the clinical part is good, but also to be able to understand enough about these things to be conversant with these people about what it is that we need from them. That's the role.
And that goes back to, this eventually has to be something that a patient is going to take.
Yeah.
So it has to be designed for a patient ultimately, and it has to also, I suppose, be suitable for the hospital and be practical, So we talk about FMT in children.
Yeah, we can.
So some big questions. You're moving an adult microbiome usually into a pediatric patient. That's a big question, right? So I guess zooming out a little bit, does the microbiome vary between a child and an adult in terms of like what's in there?
Yes and no. So probably what we know about this is that, so we've talked before about how everyone's microbiome is unique. And what probably happens is your gut microbiome has a developmental process just like the rest of your body does. So just like a child goes from lying still to sitting up to standing, holding on to cruising around furniture to walking to running to hopping to riding a bike, right? Your microbiome goes from... And if we start this question at the very beginning, is the gut sterile when a baby is born? And that fundamental question is still one that the community tussles with a little bit. Probably not. Okay.
Oh, interesting. I thought it was.
Almost everyone who has looked at first stool samples, including our group or including myself, have found that you can see evidence of bacteria from even the first stools that you take out of a baby. Okay. So you probably have.
Where's it coming from then?
And again, this is another question. So there's breast milk's not sterile either. There are bacteria present in breast milk, and other people have looked at things like the placenta and the uterine environment and have also found evidence of bacteria. Now, There are challenges because when you do PCR techniques, they're very, very sensitive, and they can be sensitive to contaminants as well. But there's increasingly a kind of reproducible signal that there are bacteria present, at least within the baby's gut, from the very beginning, from the first time that you can look for it, okay? And then what happens is you go from a situation where you've got a relatively sterile but poorly colonized, very few bacteria, through probably aerobic colonization to begin with, because those are the bacteria that are there to begin with. And then as they come along and facultative anaerobes start to change the gut luminal environment, you start to become more an anaerobic environment, and the anaerobes come along next, okay? Your baby goes from breastfeeding or formula feeding or mixed feeding to eventually moving over to some solids, and then away from milk-based feeds and into more complex solids and into a more normal diet. So all of that happens over that first period of life, and then probably quite quickly, so by the age of 3, you're supposed to have got to an adult type microbiome. So it's probably a lot quicker than maybe you would think.
Fascinating.
But if you think about that backwards, most of the changes about your gut and your diet and your development around that side of things will have happened by the time you've got to about there. There are other things like, toddlers' diarrhea describes a situation where toddlers, young children can have kind of variable transit time through the gut, so their gut can be faster or slower. They can be prone to constipation. They can get toddlers' diarrhea where you see sweet corn in their poo and they have looser motions. So there are still things where the gut's definitely maturing, but the microbiome is thought to be adult type by the age of about 3. But before that, there's a kind of gradient upwards in terms of your diversity and your changes.
How important are the early years then in terms of your nutrition and exposure to antibiotics and such like?
So those parts are probably fundamental, and there have been, again, we've talked about the issues of what we call confounding, which is when you associate something forwards in time and you say, okay, this change here leads to this increase in risk factor here, but that could be something else that's come along that you've either not thought of or that's associated with that too. But people have described exposure to antibiotics in that first year of life as being a risk factor for subsequent IBD development, as an example. And the data's always been a little bit mixed about breastfeeding and about cesarean sections, which is quite interesting. And I suspect that's because there are so many other things at play by the time you get into adulthood that it gets diluted with time, But it's certainly, if you want to set up your microbiome as well as possible, as from an infant, breastfeeding them, weaning them whilst breastfed onto complex foods, and trying to ensure that throughout that period you've got good exposure to fruits and vegetables and things, and avoiding antibiotics where possible, but remembering antibiotics also save lives,
serve a purpose.
And so we can't always avoid antibiotics. It's not possible to do that. So that's essentially what happens in children. But the adult, and then you go through life course from the age of 3 to probably into your elderly phase, and in your elderly phase you probably have a reduction in your bacterial diversity again, and you probably go into a kind of declining phase of your microbiome in that last phase of life. So in the middle it's probably relatively consistent, but it might be perturbed by big events like a course of antibiotics, like that holiday to Tunisia that we talked about before. Yep. So holiday to Tunisia, buy them now. I've never been to Tunisia.
Don't take my pill.
I don't know why that came out. I've nothing against or for Tunisia. It just seemed to be the place that fell out of my brain on this particular day. But a bacterial gastroenteritis or something, might perturb that. So, but I do think it makes sense to treat children with childhood microbiomes if you're able to do that. But I recognise that commercially that's very challenging.
So difficult. Because there's the elements of informed consent, which you would require to take the donation. If the screening is in line with consensus guidelines for adults, there are multiple blood draws over 0, 30, 90, or however I think it's every 30 days in the consensus. Then there's the whole questionnaire piece, and it depends on the age of the child. Are you really going to do a big questionnaire on a child? Yeah. And if so, what's important? You're not going to ask about sexual partners and so on and so on. So you need a completely different set of criteria to what exists now. And how practical is it?
Well, so you've got a compromise to make, haven't you? You either accept that children, if they're going to be treated by FMT products that come from adults, are going to get adult FMTs, okay? Or you accept that this is important enough that we need to go through that whole process for children. And I don't know that we really know the answer to that,
We don't know.
But I suppose I would, being an advocate for children and children's research, it is important that children don't just inherit whatever comes from adults by default, because their physiology is different.
Absolutely.
The diseases that they have and the way that they get them is different, There's an old maxim in pediatrics, which is children are not just small adults. And in a lot of ways they are, but in other ways they aren't. We talked about the sort of neurological development of children, but the types of diseases that they get are very different. They're much more prone to acute infectious illnesses. The kinds of cancers, for instance, they get are very different. The
infections they get with cancer are different too. It's different viruses that are at different levels.
Yeah.
And so, I think that as the CEO of a company that is getting really good at collecting poo from really screened people, I think that if the research or the science said for kids, you need to collect stool samples from children, I think the industry would figure out how to make that happen.
Yeah, I agree with you. I
think they'd figure it out.
But
clearly, that question, how do we get to that? I don't know.
No, it's difficult, isn't it? Because you would have to actually prove a difference, you would have to be doing something in that sphere where you're taking pediatric FMT and giving it to children and proving that that's somehow better or different to adult FMT. But, I'd be interested in your approach to smoking within FMT donors. Do you make that an exclusion criteria?
Yeah, I do.
So
there's ash in stool.
Yeah.
You can... I don't know what the analytical method is, but it is the case that there's ash in stool in smokers. Now, on the UC thing, it's kind of interesting. We were always taught at medical school
it's protective.
Yeah. But with it comes all sorts of other very damaging effects, like increases your likelihood of basically every form of cancer. And so we exclude for smokers. And tell you something interesting. In Spain, the consensus guideline says you can't smoke non-smokers, but if you smoke less than 5 a day, it doesn't count.
Then you're okay.
Because that's the social smoking element. Okay. And I questioned the people who wrote the guidelines, and it's just a societal thing. Said, less than 5. Everyone does that. So,
but that's an example, I suppose, I would say, where I would probably be anxious about putting a smoker's microbiome into a child over putting a non-smoker's microbiome into a child.
For sure.
And why? And again, this comes back to that whole okay, am I being a scientist here? Or am I just being an irrational person who's having a hypothesis about something? But, we're probably starting to get an inkling that the microbiome is important in the development of various adult cancers somehow. So what does that then mean if you're imparting that microbiome into a child 20 years, 30 years before they should have had exposure to those things,
But equally, you could, just to play devil's advocate, you could say, we're only going to collect from people who are 80 years old and above and who've not had any disease because they're less likely to get...
They've lived that long.
They've lived that long and they're healthy.
That they're great,
Yeah, exactly. But you wouldn't qualify as per the current BSG, HIS joint consensus guidelines on donor criteria screening and all the rest of the FMT preparation application because there's a cutoff, which I think is 60 years.
Okay.
And I always give a thought experiment and I can give you it.
Yeah.
So you need FMT. You've got multiple recurrent C. difficile infection coming back in every 2 weeks, quality of life's down, weight loss. And you have an option. You can take FMT number 1 or FMT number 2. Now, FMT number 1 has been prepared using donor material from an 18-year-old just back from Ayia Napa, heavy booze, had an STI 5 months ago, treated with antibiotics, but longer than 3 months ago. Quite promiscuous. It's just
it's very specific FMT product literature.
Quite
Does that come on the leaflet?
Well, quite promiscuous, but still always safe, and really bad diet.
Okay.
It's McDonald's all the time. No harm to McDonald's. Deep fried Mars bars, Buckfast, that kind of thing. Number 2 is from a 90-year-old, super fit, lean, predominantly veggie, sometimes Mediterranean diet, never smoker, never drinker, looks like they're 50. Just body's a temple. They look incredible. Which one would you rather have?
I'll take the vancomycin.
That's not allowed. That's not an option, man. After all that. Oh, man. Well, you can have your vancomycin again then and get recurrence within a couple of weeks. But the point is...
Yeah, I get the point. I think...
point is, one of them meets the guidelines.
Age is irrelevant in that context. But I suppose the other question is, let's say your 90-year-old hasn't had colorectal cancer screening and she has a Jukes B carcinoma in her rectum.
There we go.
But
we do fit testing.
Yeah, but it's got to be careful to step out my own realm of particular expertise. But I suppose the question is how sensitive is that to fully exclude? And we could go round the houses about what makes a good donor and how you choose people, and
for sure.
But
that's a podcast episode. It's coming.
The reality is we don't know, and so a lot of these decisions, we're trying to make good decisions based on what we do know or what we hypothesize, and that is the more healthy you are as an individual, the fewer diseases you have, the fact you're a non-smoker, if you've got normal weight parameters, etc. Those are probably good things.
It makes sense.
Yeah.
Theoretically, I mean, I guess there's some argument to say, and I've heard it from Professor Julian Marchesi in Imperial, we might be massively over-excluding all these theoretical, potentially microbiome-mediated things that whittle your donor pool down.
Yeah.
What's actually the evidence for that? But going back a step, in IBD, there have been some cases of flares post-FMT, is that right?
Yeah.
But the majority, they don't get flares.
Yeah. So which is interesting, because
what is it about the people that are getting the flares, do you think, that's making them?
I mean, it might be nothing to do with it, I suppose, as well, if you hypothesize, you would think, okay, we'd think IBD is predominantly microbially mediated disease, if we think that, and you're giving someone a big dose of different new microbes when we think that they're primed to respond to microbes. So it kind of makes sense that if you give people an FMT and it doesn't work, that it should lead to flare in some people, It's probably more surprising that it doesn't lead to flare in more people, And
is that's a real thing? I mean, you've got some experience yourself, haven't you? You've performed FMT. Like, what have you seen in your practice so far?
So I think when we do these studies, we always look at adverse events and serious adverse events, and we collect data on that, and all these trials do, and you then compare what you see in one group with what you see in another group. And I suppose what I would say is you're not seeing a really strong signal that FMT is way worse than giving a placebo for the emergence of these sort of adverse events and things like flare. There may well be a small signal, but there's not a serious signal there, and that in itself is quite interesting, because you might hypothesize that you'd see more, but again, there's a first of all do no harm thing, which is you don't want to give somebody a therapy that might make them worse, but I suppose if you weigh that up against the possibility of them getting much better, then maybe in some cases it's worth it. And I suppose that's a question for our patients that we need to take forward, isn't it? As we do better, bigger studies, we'll be better able to define what the real risk of flare is, and who we think, which patients we think have a higher risk of that than other patients.
Because right now we don't know that at all.
I don't think we really know that at all. Yeah, I don't think we really know that at all. And that might be partly to do with what baseline therapies and stuff people are on. And again, across the studies that are published, there's a huge range of patient populations and therapeutic approaches. Some of the studies allowed people who were on steroids and had them try to wean the steroids, and some of them didn't want people on steroids.
So on that point, do you see FMT or microbial therapeutics replacing the immune system dampening or like blocking therapies? So you've mentioned the steroids, and then there's also the antibodies. And
I mean, that's the dream, you know. I would love to come back to you in 10 years' time and have this conversation again and say, isn't it incredible what's happened? You know, all these drugs that I used to use. Oh, remember we used to use infliximab, you know, and we're now getting someone with an IBD diagnosis and we're characterizing their microbiome and we're treating them very specifically tailored to them with an intensive course of whatever it is. And then after 4 weeks, we're stepping down and we've fixed Humpty Dumpty. You know, we've cured them and they go away and yeah, okay, they might come back in 18 months and need it again. But actually in between those times, we've not given them anything and they're just living their best life.
Yeah, I mean, you can see me smiling. It's so exciting. So
it is exciting.
Super exciting.
It is exciting, you know, and it might be possible, but we don't know that yet. And I suppose I am enough of an optimist that I want to pursue that until I'm sure that it's not possible. Do you know? I would love nothing more than to throw away my prescription pad and never give another immunomodulator, immunosuppressant to a child with IBD. But you know, go back to this pragmatic word, I also have people who've got a very significant condition that impacts on their life. You know, I see semi-professional footballers who have stopped training because they've lost so much weight and energy and they're having diarrhea 8 times a day with blood in their stools, you know. So
when it's at its worst,
yeah.
When it's at its worst, what's it like for these patients?
Oh, I mean, the worst form of IBD is what we call acute severe colitis. And, you know, we probably see about 10 patients a year who get admitted to hospital with acute severe colitis in Glasgow. So that probably means there are about 20 across Scotland and probably about 200 in the paediatric population across the UK per year admitted with this, okay? And I've done those numbers off the top of my head based on rough percentages of population. But
Understood.
In acute severe colitis, you have a really sick, swollen colon that is friable and bleeds easily and is not really functional in the way that it should be. So you have diarrhea probably 8 to 10 times a day, including overnight. You have blood in all your stools. You have severe abdominal pain, and you're very sick. And it's really impossible to function in any way in that state. So these patients end up hospitalized, and we give them intravenous steroids. And if that doesn't work, we give them intravenous infliximab, and that usually works.
What does the steroid and the infliximab do? Like, how does that work in the body?
Yeah, so they're both immunosuppressants. So steroids are quite a broad immunosuppressant and have been used for a long, long time in inflammatory bowel disease. Infliximab is a newer, more modern immunosuppressant called a biological, which targets a particular pro-inflammatory protein called tumor necrosis factor alpha. I don't know why it has that name, but that's what it's called.
Right.
And it's been shown to help reduce inflammation and heal the bowel in IBD. So between those two drugs, that helps most people get back into remission from acute severe colitis, but we still have some people in that situation who the drugs don't work for them and they need to have their colon removed as part of their management course. You know, so
kids and teens sometimes have
still
the colon
happens,
to happen.
Still happens.
We should all be working as hard as we can to make sure that doesn't happen at some point in time in the future.
Yeah,
you know, with all the new therapies and diagnostics and
actually, interestingly, so we're hypothesizing about whether or not we could ever move away from those drugs, and that might be one indication where we can't move away from those drugs. You know, because you're talking about the sickest possible cohort of people who need that process switched off, and those drugs are
quick.
Those drugs are very effective at that, and that their colon is in a dreadful state. So the prospect of going into that colon and filling that with bacteria to try and recolonize it without doing anything to address the inflammation, that might be the group where they get worse or it provokes
or worse, worse than the IBD. You could get something else. Yeah,
or they have sepsis or whatever. You know, so we've got to be careful about that along the way as well. And I think when we come back in 10 years.
Podcast will still be going, episode whatever
probably episode 357. When we come back, I think what we'll probably find is we're in a hybrid state where we have newer and better, more targeted drugs that we're using to try and achieve remission and to maintain remission, but we've also got more targeted microbial therapies in our arsenal and in some patients that might be enough. But it might also be a part of their journey where we can use those sometimes to switch off disease flares and rely on drugs at other points. So I think it will be part of our arsenal, and how and when we use them will be mixed up with drugs. And, our more severe groups will always need drugs. I think surgery will, unfortunately still always remain a part of this journey for IBD patients.
When the medical treatment's latest.
Yeah. But yeah, I think microbial therapeutics will grow, and I suppose, the huge optimist in me thinks that they will become a major part of treatment.
I feel the same, of course, and that's part of the reason why we're doing these podcasts, is to try and think about the future and also talk about what's coming to try and make that a reality, the clinical studies and so on. I spent a very limited time as a doctor, but whenever I saw someone with IBD, I did say, look, I think there's quite a lot coming in the pipeline.
Yeah.
Some's in phase 2. One drug was like an antagonist for something called FIMH, which is, I think, what the adhesive invasive E. coli kind of uses to latch on to. Some people think that that's part of the pathogenesis of Crohn's disease. There's other more complicated consortia, like 8 to 10 different strains in phase 2. And I also, of course, cited the FMT data, which is increasing all the time.
Yep.
And whilst I fully accept that it's like impossible for you to implement it in your clinical practice now, because, as we said, do you give 40? Do you give 2?
Yeah.
Is it an enema? Is it a capsule? Is it so and so on? But one would hope that within the next few years, we've drilled down even further. I think that the dietary manipulation as well, whilst that makes sense, does complicate matters quite a lot, doesn't it?
It does, yeah.
So what do we do about that? Because we spoke at the start about EEN being like 4 out of 5 success. Like, that sounds like a home run. It's phenomenal.
Yeah, it is. Yeah.
Does it get less effective over time, or can you just keep putting people onto EEN?
Maybe. So yes, it does. So if you actually look at the raw data, you probably have a deteriorating efficacy from EEN each time you give it. Okay, but we recently published a paper that looked at gluten immunogenic peptide in stools of people who had courses of nutritional therapy, and we found that basically, if you have this protein, then it says that you're having some gluten in your diet, and if you're on a course of EEN, or if you're on our solid food based variant of EEN, which is CD treat, they're both gluten free. You shouldn't have gluten immunogenic peptide in your stool. So if you do, you're not doing exactly what you're telling us. Okay, and we identify,
which I guess in some respects it's understandable.
That's human
tough.
nature, right? It's a hard thing to do.
It's really tough. Think of all the things you can't eat that taste good. It's a lot, right? Yeah.
It's a lot. But we definitely saw an association between people who had this present and the success of their course. So I think what I'm interested in, I suppose, is if you're at your sickest and you've just presented with Crohn's disease, and we give you this course, then you're going to take it because you feel rubbish, and we're telling you, and you don't know any better because you've not hit Dr. Google yet, or you've not got your own lived experience, or you've not met other people who have the disease, and so you take it and you feel better, and that's great, and you comply with that. But the next time we ask you to do that, you remember what it was like last time. You remember the birthday party you couldn't go to because you didn't want to, not be able to eat the cake, and how you felt. Right. And so maybe you're less invested in it the second time. And by the time the third time comes around, the fourth time, you're maybe fed up, unless you're really motivated. And so
what I've got written down is, and you're maybe just about to get onto it, is which element of the EEN is driving the effect. So what is it? Because I suppose if there was some small bit, like, for example, don't eat or drink foods that contain X, it would become easier for patients?
Yeah.
Or is it the physical, solid elements?
It's not solid. No, it's not to do with that. So, probably the most interesting parallel to think about is celiac disease. So in celiac disease, the body has an immunological reaction to gluten within the diet, and when the gluten is in the diet, the body reacts to that as if it's an invader and causes inflammation, predominantly within the small bowel, and the patient gets diarrhea and abdominal pain, and they maybe lose weight and they don't do very well. And as soon as you take gluten out of the diet, that all switches off, the bowel heals, and you're normal. And as soon as you put gluten back in diet, it returns again.
Is that a microbiome thing?
So no, it's not a microbiome thing.
No. Not everything's a microbiome thing.
Not everything's a microbiome thing. Probably not a microbiome. But I bet someone studied it.
For sure. Yeah, for sure.
But so in that context, the target is gluten. Take gluten protein out of the diet and you've fixed celiac disease. Put it back in and your celiac comes back. Okay, so that's a pretty simple model in a way of what a diet could look like. But when you start running that into practice, it becomes quite complicated because that's all, that's all wheat, that's all pasta, that's most beer, So you're starting to pull things out your diet and you see how challenging that is. But there are societies that will help you with that, and you'll get dietetic advice, and you might even get foods on prescription that are gluten-free. So when you roll that into Crohn's disease and you think, okay, what's going on with this diet? We know that the liquid-only diet works, as we said, in 4 out of 5 people. We've started to understand how it works. So again, my friend and colleague Kostas Garasimidis did the sort of key work on this, describing what happens to bacteria when you give a course of exclusive enteral nutrition, and it seems to be a paradox. Instead of your bacteria, so your bacterial populations are already suppressed in Crohn's disease, you've got reduced bacterial diversity. And when you give exclusive enteral nutrition, they're further suppressed. So you might think that they get better, but they get worse. If you plot them on a chart...
The diversity element.
Yeah, if you plot them on a chart as what we call a principal components analysis, which takes all the microbiome data into an XY plot of the numbers don't actually mean anything, but if you do the same test on the same group of people all the time, it'll plot in the same place. And so people who are similar plot next to each other. Then you've got healthy volunteers over here, and you've got your microbiome for Crohn's disease over here. They move away from healthy volunteers. So your microbiome gets more dysbiotic and gets lower diversity, gets more suppressed. So, and yet your disease gets better. So there's a paradox there. And I think what exclusive enteral nutrition is a microbially suppressive therapy. And how I talk to my patients about it now, really in the last few weeks, actually, I've kind of come to this way of describing it is the way it works is it feeds the human, but it starves the bacteria. Okay, so all the stuff that you need gets given to you and gets absorbed high up the gut, but by the time it gets to the distal gut, there's so little substrate left for the bacteria that there's nothing for them to do. And so they basically become somnolescent. They go off to sleep and they stop causing the trouble that they've been causing. And then your disease gets better.
Wow.
And that's also reflected in the fact that when you've given a course of exclusive enteral nutrition and you put people, that all just falls out as one big word, there's lots of syllables, and you put people back on a normal diet, you start to see the inflammation switching back on again very quickly. And within 2 weeks, their calprotectin has risen back up again. And then, most people will have a disease flare back to where they started within a year if you don't do anything else about it. So it's a very effective therapy, but it's really specific.
So how do we create a less socially restrictive, microbial suppressing diet?
Yeah, so we've done that. The team in Glasgow, again, my colleague Kostas Garasimidis, but also a chap called Vios Svolos who did a PhD developing this diet, but other colleagues as well within adult gastroenterology here and paediatric gastroenterology and adult gastroenterology in Edinburgh. So it's a very Scottish initiative. We've developed a diet called CD Treat, which is Crohn's disease treatment with eating. And it's a solid food diet that basically is modelled on exclusive enteral nutrition. So the idea behind CD Treat was if it's in exclusive enteral nutrition, it can be in CD Treat, and if it's not, then it's not in CD Treat. So, but using real food. So, for instance, we've already talked about how exclusive enteral nutrition is gluten-free, so CD Treat's gluten-free. When you're on exclusive enteral nutrition, you don't take alcohol, so CD Treat's alcohol-free, So we matched it as closely as possible for macronutrients and micronutrients, but using whole foods. And we got philanthropic funding from the Helmsley Charitable Trust, and we've recently completed an open label study of the diet in children and adults with Crohn's disease, and it
published.
We're drafting a manuscript as we speak.
I wouldn't push you on it then.
So, but we're very encouraged by the results.
You can come back when it's published and tell me all about it.
We're very encouraged by the results. And I suppose if CD Treat works, one is it gives you a version of this that's much more palatable. You can take a sandwich to work, you can eat soup with your family, you can sit down and eat a meal that's recognizable as solid food, so you maybe don't feel as socially excluded as you do on exclusive enteral nutrition. But maybe more importantly than that, it then gives us a baseline on which to develop. So suddenly you've got a testing platform. You can say, okay, CD treat plus gluten, or CD treat plus, whatever it is that we want to throw into that to say, and how does this change things, and is it still effective?
So it's like a reverse elimination diet. You're just adding stuff back into the platform and seeing what happens. Oh, it's fascinating. What's the ultimate aim then with CD treat? Is it trying to get someone living as normally as possible without a flare, essentially?
So I suppose there's two facets to this. There's the therapeutic facet, which is, can we give people dietary therapies that can drive their Crohn's into remission, or maybe even control their Crohn's and stop it going into a flare in the first place, that are livable and palatable and can fit into a normal life. And that's certainly an exciting component of what we're doing with the CD Treat program. But the second question is actually, what does it tell us about disease biology? And that comes back to what we talked about earlier about these binary questions, So, how do we predict responders against non-responders to this? And that's where the non-responders are not disappointing. Everybody would like to test something and have everybody 100% response and say, oh, this is great, look how wonderful it is. The reality is never that, but in that percentage, whoever they are that don't respond, they're telling you something. There's a signal there to find about
they're just as
what's
important,
different.
Perhaps.
Yeah, easily just as important, if not more important, because if we actually start to understand the disease signals about, I've given you a crude understanding about how dietary therapy might work in Crohn's disease by suppressing the microbiome, but what's it suppressing? Is it just one bacterium, or is it a consortium of bacteria? Can we identify the key players that might be important?
Is your view that the key players are the same across all people with the disease, or is it more like you lose a function or you gain some bad element because there's a lot of functional redundancy?
I think the latter. I think we're talking about a phenotype of bacteria, and whether that is what they can do. So we put forward this idea of, you mentioned adherent invasive E. coli, but Campylobacter seem to be important in the Crohn's story as well, or people have associated Campylobacter concisus with Crohn's disease. But it's a proteobacteria, and it's also adherent and invasive. And so it might be that bacteria that have particular properties can exploit what's going on in the immune system in Crohn's disease and drive this disease process. But it might not always be the same bacteria. It might be bacteria that have similar properties,
Going back to we touched on briefly the Amazon sort of higher diversity microbiome versus us and the differences in disease. Are there cases of IBD in indigenous populations, or are they just they just don't get it? Because I read that they don't get autoimmune disease in anywhere near the same incidence as the Western population.
I don't know the figures. I would be guessing, but I presume they probably do get it, or probably would get it, but probably at a much lower rate than we do. What is clear from the literature is that as you move to areas where IBD is endemic or much more common, your risk starts to take up that of the population that you've moved to. So that would suggest.
Oh, really?
That, yeah. So if you're an immigrant family that moved from one area to another area that's got IBD, then you're more likely to get IBD, and then the longer you stay there as a family, the higher that risk will go until it eventually reaches that of the local population.
And that supports the environmental hypothesis, so to speak. So we've spoken a lot about bacteria, but there's more to the microbiome than just the bacteria, right?
Yeah.
So what do you think is the relative importance across the different microorganisms in the ecosystem in terms of driving disease or being associated with health? You mentioned at some point that they were the bacteria the most abundant. So there's more of them than others, or they're the easiest to culture?
I think there have been more studies done in bacteria, probably because the people applied the technology earlier to bacteria. I suppose one of the weaknesses of the field is that there is no, and maybe you'll get a scientist on who'll tell you that this is wrong, but from my point of view, there's no unified approach to sampling we'll call it bacteriome, the fungome, and the virome. Okay, so they're probably the three major constituents of the microbiome, and you can't currently throw one sample onto a machine and get all three of those out together as a unified data set. You can explore
You've got to extract different
each
elements
of those distinctly, but trying to do that as a unified whole is currently beyond the abilities of science. And I suppose that's where we get back to things like machine learning about trying to integrate those sorts of analyses. Is we should be paying as much attention to the virome and the fungome as we are to the bacteriome. And I think we're probably starting to. But I think that's probably coming attractions, is how do we start to think about the microbiome not just as the bacteria because that's convenient. It's the presence of the 16S gene that led us down that sphere. Fungi have got an 18S gene that you can sequence as well that does a similar thing, or an ITS gene which can be used for a similar purpose. But those are obviously different PCR amplifications, and then how you've processed your sample becomes important because fungi are much more robust and have stronger cell walls than bacteria. So how do you make sure that you've captured all of those? So there's a lot of things that starts, the difference between DNA and RNA viruses and whether you can capture them all and how fragile that RNA is through this whole process. There's a lot of things that we need to think about to be able to look at all those different aspects of the microbiome, but it's going to be important.
So it's
nuanced
and it's...
What about things like helminth infection? Helminth colonization is prevalent within world human communities. We don't think about it too much in the West, but that's also officially part of your microbiome because it's a living organism that's within your ecosystem.
And we exclude people with helminths in their gut. But what we're seeing is that in other parts of the world, it's just normal.
It's just normal. It's probably normal for humans. So it's probably normal for humans to have helminths in their gut and H. pylori in their stomach. And
the H. pylori is interesting.
Over 100 years, we've stopped that.
That's interesting. So the H. pylori piece then, do you think we've just evolved? Is there some evolutionary advantage to H. pylori? Or it's just there and it's something we have to accept?
Well, we've not accepted it. I suppose that's the thing. There was an editorial in the Lancet quite a long time ago in the 80s when H. pylori was kind of newly described, which said the only good H. pylori is a dead H. pylori. I think that was the title of and that was the kind of prevailing idea about this organism, was when we find it, it's always bad, get rid of it. And that's because when it was first described, it was associated with peptic ulcer disease and gastric cancer. And those are bad things. And so if you associate this with those, then you want to get rid of it.
Was there a Nobel Prize with that as well?
There was indeed a Nobel Prize. So Barry Marshall and Robin Warren. Barry Marshall, who famously infected himself with H. pylori to prove...
Not recommended.
Not recommended. No. He did know the antibiotic sensitivities of the organism before he did that, and he did eradicate it from himself quite quickly. But he did self-infect.
Some of these old school scientists, they're just bold.
But H. pylori, again, it's now quite rare, and I would probably estimate that in the UK we're probably less than 1 in 20 kids have probably got H. pylori now. It's hard to have exact data on that, but I take that data quite crudely from what the positivity rate of the tests for H. pylori were in our unit in Aberdeen when we were doing them, and it's not a population sample, but that's where I take that from. So it used to be much more prevalent than that. And there is now an association between, H. pylori may be protective against other autoimmune conditions like IBD.
Wow.
So it might be that we've somehow changed our gut's immune response to this bacterial organism that used to live there all the time. And that one of the net effects of that is an increased risk of things like IBD.
That's fascinating. So there's just still so much to learn. And that's been one of the recurring themes over the course of this conversation, hasn't it? It's like...
I think so.
We've learned a lot, but that should distill loads more. Mark, how are we for time? Because sometimes time just flies.
I better go for my dinner.
Yeah. Richard, thank you, man.
No problem.
That was awesome. Sometimes that just happens.
So put a date in the diary in 10 years.
Yeah, 10 years. No, well, when you publish some of your CD treat stuff, I'd love to have you back on to talk about that.
Yeah.
You can show us the graphs and stuff like that.
Sure, that would be nice.
So interesting.